Yeah, thank you very much, Krista. I have two questions. Krista, your data are very impressive, especially the video with your open chest. And I know that the babies and the rats have a tonic activity of the diaphragm, but in adults we do not observe this tonic activity. Do you guess that we also have such a reflex that the adults can recruit their lung by themselves?
You mean for adult patients? Yeah. We looked in a population of normal ICU patients. We didn't see much of tonic activity. I've seen anecdotal information from severe ARDS where you see tonic activity. And I've seen definitely when you have a pneumothorax, you have immense tonic activity. But that's technically all I can give you in the adults. What I can give you, though, is more like the COPDers, that they have always been described to have post-inspiratory activity, which is actually probably an active process to prevent high expiratory flows at the onset of inspiration in order to probably reduce the P.1, sorry, not P.1, what's it called, the expiratory flow limitation. So there are some things like that. But as I'm saying, the upper reflex is definitely there, but it's very close to TLC. But the thing is, if you increase NAVA levels in the adult patient, they will not increase the tidal volume. They will not. If you take away the PEEP in an ARDS patient, I'm pretty sure you will see tonic activity.
Maybe I have a further question to that. To the cycling off, I mean, we have still also in NAVA cycling off at 70% of the peak signal. Do you guess this is physiological, or should we remove that we have a NAVA for the whole inspiration?
Well, if you look upon NAVA, it's kind of a, as I started, like begin with the point that either the machine breeds you or you breed the machine. If you would breed the machine, you would not like it to stop and start. You would like to have assist continuously because that's how your respiratory muscles work. So if you share with the muscles, I think you should share with the muscles during all phases of a breath. The trigger that the flow reverts is kind of like just that's why you see the thing when you have intrinsic peaks. So when we do the neurally triggered pressure support, we never see this blip because we overcome the intrinsic peak immediately. So you can see this as an elevator on its way down. So instead of coming to 0 floor, it will stop on the 3rd floor and start to go up again. If you want to have intrinsic PEEP, you have to lift the first 0 floor up to the 3rd floor in order to make it happen. So that's what we see also in this case, that we never see the EDI go down, which means that they actually do get hyperinflated when they have NAVA, as much as they do when they get extrinsic PEEP, even if it's set at 80%. So again, I think there are very few studies that actually shows that the hyperinflation doesn't take place. It's kind of more like some studies that just brought it on to more to be accepted. I think that hyperinflation during intrinsic PEEP is must, and if you put positive pressure to counteract it, I think you simply bring the level of pressure up to the point where the air should reverse, and that means you stay hyperinflated in that situation. You don't increase it, but you don't decrease it.
Just a small comment on the first question you had on tonic activity. In the study, I presented the results from the infants, but we also have 20 children older than 1 year and who should not have, who don't have tonic activity usually. But during their PQ stay, about a third of them activate some tonic activity at a certain point. And it has also been shown in adults with asthma, which is also a bit the same physiology of bronchiolitis, and this is a discussion in asthma. So if some part of the hyperinflation is not induced by the patient and by the muscle activation of the patient.
There is actually a study or two with NEP, or whatever it's called, negative expiratory pressure, where you actually put people on a vacuum cleaner technically, and then you get tonic activity.
Ling, can I ask you a question? The neurally adjusted pressure support, is there some advantage to that over the use of NAVA?
Okay, you mean the neurally controlled pressure support versus NAVA?
It's neurally triggered pressure support, what you presented.
Yeah, the trigger. We said that the same. We use NAVA mode, and we said the EDI trigger 0.5 make a wall, and we just set the pressure limit to get the pressure targeted.
Yeah, this is neurally triggered pressure support.
Yes.
Is that why do you think we need a mode that's neurally triggered pressure support? Isn't it just better to use NAVA, or do you think there's something special about neurally triggered
Yes.
pressure support that's better than NAVA?
Yeah. So during NAVA, it's a proportional mode, and the pressure will increase slowly. But for the COPD patients with intrinsic PEEP, maybe we need immediately a high pressure to overcome the intrinsic PEEP. So we need the pressure to go up immediately, and so we set the neurally controlled pressure support.
I think also one aspect. I mean, from the triggering point of view, when you have intrinsic PEEP, if you want to run with 0 PEEP, you have to get to the PEEP level immediately. Otherwise, you will see the PEEP coming out. That's the pressure you first see. So that you need to compensate for. So instead of having PEEP during exhalation, you would get PEEP during inspiration instead. So pressure support has an advantage there. I think the other part, which is maybe even more important, is for uncontrollable patients, as we talked about before. So the patients where you, for example, in NAVA, if you would have to paralyze them in order to keep them down in drive so they don't really damage themselves, but still take advantage of the neural control in terms of recruitment and other things and stay recruited. That, I think, is probably where we might have sometimes to put the cap on the pressure. And last but not least, I think 60% of all patients treated in the world are on pressure support at least some part during their time. And this mode fails at about 25% of the time to keep synchrony. So why not just make it synchronized?
Yeah, I just wonder if you're putting a catheter in already, then is there a real advantage?
Yeah, another advantage that was presented last time here by an Italian team, I think maybe Pesanti, I don't know who exactly, but it was for the non-invasive ventilation with helmet, which has a very large dead space, and there's an advantage that the pressurization is very rapid.
I think I saw a microphone go there.
I have a question for any of the speakers, maybe a silly question, but just to think about. Since this morning we've been speaking about the tonic activity of the diaphragm. We are measuring here the crural diaphragm. The crural diaphragm is involved in respiratory function, and I agree that it will maintain the end expiratory volume, but it is also involved in many other functions. For instance, we could think of the anti-reflux barrier function, the crural diaphragm. So maybe that in some circumstances where we don't understand why the tonic activity of the diaphragm is increased, maybe that could be related to any other function of the diaphragm?
This is a great question, and this may be a specificity of the infants. What I would say that is the results that I show you are a relatively stable period, because sometimes you have huge amounts of tonic activity, which may be recruitment desire, or which may be postural or defecation, or I don't know. It could be other kind of activity, and so it's very complex. But the diaphragm is active, so it tends to increase the lung volume in the end.
So I have a question for the audience. Who wants a coffee break and who wants more questions? I think I see coffee break. Okay, thank you very much.